everybody. This is just an overview of Module 2B. What we were going to look at in this module are basically benign skin tumours, skin biopsies, a little thing on curette and cautery, dermatopathology of skin stains, a reasonably sophisticated topic, and I'll go into that in some detail though, and a little tutorial on erythematous plaques on the face. These are the things that the registrar is going to answer or we'll go over on the night of the webinar. A little bit about immunoperoxidase stains, why they're used by dermatopathologists. You've got to know a little bit about these and understand sometimes when you have a specimen you send in, the pathologist gives you a provisional diagnosis and says, I'm going to do some immunoperoxidase stains and I'll send you an additional report. Then we'll get the registrar to look at the differential diagnosis of granuloma faciale. That comes into this one on erythematous plaques on the face. Then, as a surgical topic, have a little look at the drawbacks of curette and cautery on the face. Then this little tumour, would you regard a microcystic adnexal tumour as a benign lesion? And we'll talk a little bit about it. But probably most of that I'll actually leave to the webinar itself. This lecture here basically goes over the images that were in the diploma module on benign skin lesions. So it's a quick overview of most of the images that you're going to see. It's worth having a little look at. You're going to see a lot of benign skin lesions, just in general, in ordinary practice, examining patients. The older people get, they start growing a whole lot of appendages on the skin. They start involuting some of their nevi, but they seem to grow more than they lose. And so you've got to be able to recognize all these benign skin lesions. Seborrheic keratoses are going to be the commonest thing that you're obviously going to come across, and they still give us an awful lot of trouble when we're looking with dermatoscopes, especially the very flat ones. You know, seborrheic keratoses are really an acanthosis, is a thickening of the epidermis. But in some people, because they can be quite highly pigmented, they may even show a sort of network pattern. They'll certainly often show a blue structure that you may misinterpret as a blue-grey veil dermatoscopically. And simply it's a lot of melanin and keratinocytes. So you've got to be aware that they can mimic melanoma both clinically and dermatoscopically. The condition stuccokeratoses. These are lesions that are seen on the ankles. They're a variant of seborrheic keratosis, and I think Steve Cossard's father Emery wrote one of the first papers on stuccokeratoses. Dermatosis papulosa nigra, a very common condition that you'll see particularly in Asians and also in Afro-Americans. I think there's an image down here of these. And you can see that they're very seborrheic keratosis-like. I'll get you to read through all of these various benign lesions. You've just got to be familiar and aware of them. Eruptive vellus hair cysts are quite interesting. We don't see those terribly often. This is a section in DermNet on eruptus vellus hair cysts. They are typically seen on the anterior chest wall, and they may be seen along with steatocystoma multiplex, but there are multiple small little cysts like this that are commonly seen, as I say, on the chest wall themselves. They may be familial. It's one that we don't see that often, so it's useful just to get your head around eruptus vellus hair cysts and what to look at. So have a good read at that DermNet reference on it. And steatocystoma multiplex lesions, they've said here, small oil-filled cysts, anterior chest wall along the sternum. So they're seen in the same area as eruptive vellus hair cysts. I've said there they may occur in association with them. The hydrocystomas, you'll see them quite commonly, usually around the eye. They're little clear fluid-filled vesicles. The apocrine ones can look a bit bluish as well. The ecrine hydrocystomas tend to have fairly clear fluid. The digital mucous cysts or myxoid cysts, these will generally present with a depression in a nail. So often the patient will come in with this sort of furrow in the nail itself, and if you look at the posterior nail fold, you'll find a bit of thickening there. So look at some of these. They can be misdiagnosed. There's section in here on the sign of lesser Trelat. This is the eruption of multiple seborrheic keratoses in someone who may have an underlying malignancy. Now, it may be lung, it may be gut. It sometimes is a difficult diagnosis to make. Often the seborrheic keratoses, when they erupt, they're actually quite inflamed as well. So if you see someone who's got a lot of inflamed seborrheic keratoses that have come on their back and chest recently, then it's worthwhile looking at them to see if there's any sign of an internal malignancy. And gut, stomach, colon, lung would be the things to look for. These are the little references that are in there to stockokeratosis, dermatosis papulosa, nigra, and dermnet. Worth having just a little look there just to get reminded as to what these lesions actually are. Dermatofibromas, they come in all shapes and forms. That's the typical clinical picture here, where you do squeezing pressure, and instead of going up, they pop down the way because they're tethered down by the collagen in the dermis. Look at the hyperpigmentation. Usually you get a little clear area at the center, which dermatoscopically correlates with the collagen that's there, and then you get usually a rim of pigment. And it's a reticular network that will show dermatoscopically as well. But the degree of irritation that you can get of the overlying epidermis in dermatofibromas is quite considerable. And they can be mistaken for melanoma, especially just on the dermatoscopic view itself. So have a little look at the many variations of dermatofibromas that you may in fact see. Obviously the keloid and hypertrophic scars you need to know a bit about, how to treat them, the problems that occur if you try surgically excising them, ways in which, if they are surgically excised, you can try and stop them recurring. It's worth having a little read there on that aspect of it in DermNet as well. Then we go on to keratoacanthomas. You're going to see a lot of keratoacanthomas. They can occur after injury, they can occur after freezing. They come up very quickly, so you need to deal with them quickly. Most of them are best excised or curetted off. Depends on the patient, depends on the site where they are. Now, what else? Chondrodermatitis nodularis helicus. This is essentially an ischemic necrosis of a piece of cartilage in the ear. It's usually the side that someone lies on. Pressure tends to waken them at night. It's often misdiagnosed by general practitioners as a squamous cell skin cancer. If the bit of necrotic cartilage is expelled through the surface of the skin, then the lesion may settle down. A little bit of diluted intralesional steroid can be used as well, but often you need to do a little wedge excision. You'll find that it's the most protuberant part of the cartilage of the ear that tends to get involved with this process. And I think it's a combination of pressure and ultraviolet light that leads to that ischemic necrosis. Pilomatrixomas. This is an example of one here. They're very firm, cyst-like lesions. Well, they don't feel cystic, they actually feel very firm. Typically on a child's face, on the cheek like this, and they feel bony hard because within that pilomatrixoma there may be calcification, there may be bone even sometimes forming in them. So most of these I usually try and excise when they're small, but it's you've just got to be careful with children. They don't heal quite as well as the lined adults do. There are some familial types where there's multiple pilomatrixomas, and they can be associated with the syndrome or two as well. Adnexal tumors, they're multiple lesions. If you look in any path book, you'll find, the adnexal tumors are those that are arising from eccrine glands, from hair follicles, from apocrine glands, and we call those the adnexal structures, so a variety of benign and malignant tumors will arise from those. The ones that are perhaps most important, are most commonly seen, are, say, the syringomas, which arise from eccrine glands around the eyelids, and trichoepitheliomas, which typically arise from hair follicles and are seen on the nasolabial folds and around the mouth. There are a couple of variants of trichoepitheliomas that you need to know about. One's the desmoplastic trichoepithelioma. And again, it's a fairly firm lesion. It looks, when you try and blanch the surrounding skin, it really looks as if it's a basal cell skin cancer. But you'll often see little milium cysts in there, and that can be the giveaway that it's a trichoepithelioma. When trichoepitheliomas occur in association with cylindromas, which are large plum-like cysts that occur in the scalp and around the scalp margin, when you get that combination of trichoepitheliomas and cylindromas, the patient may have the Brooks-Spiedler syndrome, which is an autosomal dominant, where these two conditions, cylindromas and trichoepitheliomas, are seen together. Sebaceous tumors in general, they're not of great importance, except, we see a lot of people with sebaceous hyperplasia. It's very common in the grease areas in the face. The only thing you may mistake that for is you might think it's a little BCC because of the central dell that's there. But it looks yellowish, and it looks very different with a dermatoscope. But the ones that you have to be aware of are sebaceous carcinoma or sebaceous adenomas. If you do a biopsy or remove one of these lesions on the face, then you have to consider that the patient may have the Muir-Torre syndrome, which is the association of these sebaceous tumors with carcinoma of the bowel or the uterus or the ovary. And certainly sebaceous carcinomas. And these are typically tumors that are found around the eyelids as well. If you cut out one of these, then the pathologist can do a special test on the tissue to looking for, I think, some microarrays. And if, I forget the ins and outs of it, but if this marker isn't there, if something isn't there, then the patient may indeed have the Muir-Torre syndrome. And so they really have to be sent to have endoscopy and a proper examination of a woman for a tumour of the uterus or the ovary. Some of these patients also have an increased tendency to get keratoacanthomas. So have a little read there on DermNet on the Muir-Torre syndrome. Because syringomas are very common, it's worthwhile having a little read of those as well. That is chondrodermatitis nodularis helicis. You can see that little nodule there. It looks somewhat like an SCC, but in general it will be the most protuberant part of the ear here. This is where the bit of necrotic cartilage is being attempted to be expelled by the body. It's one of the perforating type disorders. At least I've always regarded it as a perforating disorder. So those are the main things in benign tumours that I want you to read up about. You'll know and recognize most of them. Just have a little quick read through DermNet on those particular topics. Now, the DermPath topic that we wanted to look at in this particular module was skin biopsies. Skin biopsies are obviously very important. Last week we talked a little, 2 weeks ago, we talked a little bit about how representative punch biopsies were in diagnosing the correct histological type of basal cell carcinoma. And we commented that because you're sampling such a relatively small area, if you have a biggish BCC, you may not get the correct diagnosis. You may find that there is a more aggressive subtype that isn't going to be picked up. And even with aggressive BCCs, often the initial biopsy will miss the aggressive component in about 30% of cases. So our punch biopsies, we've got to be careful in assuming that perhaps we simply deal with a superficial BCC when there may be an infiltrative component, and then we go and use Aldara or PDT or a modality that in the longer term may not be the correct modality for a more aggressive subtype. Obviously, shaved biopsies are the other thing that can be done with pigmented lesions, especially ones that are diffuse, like this particular case here. And it's important just to look at this little bit as to what layers you're looking at. I mean, punch biopsies can reach the fat layer in some areas, but areas like the back and the legs, generally they won't reach the fat at all. And so if you've got a process that's involving the fat, like, say, erythema nodosum or any of the paniculitidae, punch biopsy is useless. You've got to do an incisional biopsy that will go deep down to the fat. You've got to know where the pathology is in a condition if you're thinking about that. That's maybe the diagnosis. So that if you're going to sample it, you've got to use the proper thing to sample. Shaved biopsies, remember, you're basically just going to be including the epidermis and the papillary dermis, so you're just going to be shaving through that lot of level there. So if there's a lot of pathology down here, a shaved biopsy isn't going to get it. So, remember the limitations of the type of biopsy. The question of how you biopsy pigmented lesions is also important. You'll know that if it's a small nevus or a small pigmented lesion up to 5 millimeters that you're concerned about, then you don't do a punch biopsy of that. You do an excisional biopsy with 2 millimeter margins, and the pathologist looks at that. A flat pigmented lesion, you can do a shave biopsy, but in general you're better not doing a shave biopsy if the lesion's raised. Now you can do a deep sort of shave, and we call that a saucerization biopsy. In the normal shave biopsy, when you do it, as in this example here, what you see is this little bit of pinpoint bleeding afterwards, and that's really the papillary dermal plexus of vessels up in the papillary dermis, and you're sort of just cutting across the top of that. So you're only going through the dermis, the papillary dermis, with a shave, so you should only see that. If you're doing a proper saucerization biopsy, you'll in fact see bits of fat in the base of this, indicating you've gone down deep enough. These sorts of lesions here, how are you going to biopsy them? This may be a lenticle malignant. You can take a dermatoscope, you can look, you may do several punch biopsies of the areas where the dermatoscope's most suggestive, but often you're better doing a couple of big shaves here and give the pathologist a reasonable chance of diagnosing it. Because it's a flat lesion, shave biopsies are quite appropriate. Have a little listen to this video here. It goes into all of these biopsies, all of these situations here, and discusses them in a bit more detail. Discusses a bit about curette biopsies as well.
The broadcast is now starting. All attendees are in listen-only mode.
Down in this area here, you also have biopsies of special sites. In this one here with biopsies of the nail, I think we've said that normally if you get a pigmented streak like this, it means that the pathology is somewhere here in the nail matrix. Previously, we've said in those circumstances that you do a punch biopsy here, 3 millimeters or less, because more than that and you'll get a distorted nail. But there's a much better technique nowadays where you, in fact, put a ring block in, do a cut back here, go in under the nail, lift the whole nail, and it's called lifting the hood, and go under here as well, and you lift the whole of the nail plus the posterior nail fold here, lift it right back so that you're in fact exposing the nail matrix underneath here. And you can often see where this pigmented band is coming from. And you can either do a punch in that area or even just a good shave biopsy there. it can give you all the information you in fact need as to whether this is a benign or a malignant proliferation that's giving you a band like that. So remember this one of cutting back here and here and just using some needle holder or the like underneath here, and to lift this and lift the whole lot back to expose the nail matrix. Lip biopsies, remember lips are bad areas for metastasis if you get an SCC here, so you don't fiddle around with lips. And generally it's not a shave, usually it's a punch you're going to do here, and you're going to suture it. They heal very well, lips, but you don't want to miss an SCC. And always look inside the mouth when you're looking at patients as well, and look for areas of leukoplakia or erythroplakia on the inside of the mouth. Erythroplakia is actually more serious or potentially malignant than leukoplakia is. So they certainly need to be biopsied. It's awfully very difficult actually trying to biopsy an eyelid. If you've got a tumour here, I normally refer it because you're going to leave a notch here. So I usually get the eye specialist to deal with that one. This little video here goes on to discuss how specimens are processed and handled. It's worth having a little look to understand how pathologists in fact cut a specimen up, because they may only do they often discard the two end bits here. They may then only do 1, 2, 3 cuts through this in examining the specimen. And what this is meant to illustrate is that if you do a cut through here, you do a cut through here, your report will be that the lesion is in fact clear, whereas there's a little bit here that you haven't in fact sampled where a tumour may recur. So that's the reason why I think in about somewhere between 5 and 8% of surgically excised specimens that are said to be clear, tumour recurrence can in fact occur because it's not been adequately sampled. Pathologists themselves with pigmented lesions will often do a lot more cuts than is shown there. This is how a block's processed. This is how it's cut on a microtome. This is how the individual slices, paraffin slices here, are floated in this float bath, and they're then put on a glass slide. Then they're put in an automatic stainer, and then they're capped. And then you examine it. Now this video also looks at some of these special stains that are used in histopathology, and we're going to discuss the immunoperoxidase stains. But there's a few of these that are of some importance. Now you don't have to learn these, but you'll get reports back in certain clinical situations where special stains have been used, and that typically is where someone may suspect a Merkel cell carcinoma, because Merkel cells in the dermis can look very similar to small cell carcinomas of the lung, and you need to do special stains to separate them. It'll also be seen in a spindle cell tumour. Say you take a biopsy of something and the pathologist just sees spindle cells there. You can get spindle cell SCC, you can get spindle cell melanoma, you can get spindle cells with atypical fibrous xanthomas, get spindle cells in neuromas and leiomyosarcomas. So to separate those out, the pathologist has to do a variety of special stains for each of those cell types. And we'll talk a little bit more about that in the actual webinar itself. A lot of special stains are used with melanomas, looking for, if you're trying to distinguish between a nevus and melanoma, usually melanomas grow much more rapidly, so they can use special stains that illustrate that mitotic activity to assess whether it's more likely to be a melanoma than a nevus. But of course you can get rapidly growing nevi that are turning over as well, so you've got to watch it. Some pathologists do a lot of special stains, some don't do much at all. So we'll deal with a little bit on special stains as well. We'll also in the webinar look at some of the interesting cases in this issue of the Dermatology Online Journal. And the tutorial topic that we'll do in the webinar itself is looking at erythematous plaques on the cheeks. and they may be red scaly or they may be red non-scaly. The typical red scaly plaques on the cheeks would be things like discoid lupus, obviously skin cancer, solar damage. Don't get a lot of psoriasis in the face, don't get a lot of eczema in the face other than seborrheic eczema. Tinnitus, obviously, you can get on the face, and they'll be red and scaly. And in beard areas, you can get even Kerrion sometimes, depending on the organism. It's often the red non-scaly plaques that are more interesting, and we'll look at these conditions: Jesno's, lymphocytoma cutis, granuloma faciale. So if you want to have a little look at some of those there beforehand, that'll be good, because we'll go into it in a bit more detail in the webinar itself. We'll also have some cases that we'll look at that stage too. So essentially, this particular module is all about benign tumors. So look at the videos, have a little read at some of the references in DermNet, just brush up your knowledge of these various common things. Have a little look at the question of biopsies. Listen to that video on biopsies. Have a little think about special stains that may be used in dermatology as well. And we'll go into some of those issues in a bit more detail in the webinar itself. Thanks very much.